You are listening to the Blood Bank Guy Essentials Podcast, episode 030.
Well, alloimmunization is a medical problem, but it's a greater medical problem for some populations than it is for others. And patients with sickle cell disease are a population of people for whom alloimmunization is more of a medical problem than maybe the rest of the population taken as a whole.
Well, hello, everyone. Welcome to episode 30 of the Blood Bank Guy Essentials Podcast. My name is Joe Chaffin. I am, as always, your host. Today's a little bit of a special day, so I hope you'll indulge me for just a second. This is my 1-year anniversary episode. I started the podcast back in April of 2016, not having really a clue what I was doing, not knowing if I would be able to get anyone to talk to me, and finally, not knowing if anyone would download the episodes that I put out into the world. Well, I'm honored to tell you that in that first year, the episodes have been downloaded more than 50,000 times. 50,000, I can't believe it. You guys are awesome. And more of you are discovering the podcast each and every month. Really, I'm just happy to have found a way to connect with you to fulfill what is really my professional goal, and that's to teach the essentials of blood banking to as many of you as possible. So thank you to all of my guests, my co-host on several episodes, Dr. Heidi Chaffin, and most of all, to each and every one of you. But hey, you know what? This isn't about me, so let's move on. Let's talk about what's going on today. Today's episode features a star young physician with a name that you may not have heard yet. Dr. Eric Gehrie is here, and he's from Johns Hopkins in Baltimore. And I say that you may not have heard of him yet solely because he's really doing some great things. And to be honest, I find him wise beyond his years. He'll hate me for saying that, I'm sure. Eric is here to guide us through some of the effects of red blood cell transfusion in patients with sickle cell disease and to help us with some strategies for those transfusions. And I'm going to talk about this a little bit in just a couple of minutes with Eric, but just so we're clear, this podcast is not intended to be an in-depth discussion of all the stuff about sickle cell. We're focusing specifically on some of the effects and specifically mostly on alloimmunization. So again, I'll talk more about that with Eric in just a second. And in fact, let me not talk anymore right now. Let me give you my interview with Dr. Eric Gehrie. Well, hi, Eric. Welcome to the podcast.
Thanks. So happy to be here.
Man, it's really awesome to have you. I appreciate you doing this. You and I are connecting on an early morning, and much appreciated for you taking the time. I want to tell everyone a little bit about you. Eric Gehrie is a native of Chicago, Illinois, and where he went to undergrad at the University of Chicago, did medical school at Mount Sinai in New York, did his residency at Vanderbilt University in Nashville, Tennessee, and his blood banking transfusion medicine fellowship at Yale. He also stayed on at Yale as the assistant director of blood bank and apheresis until he moved on to where he is now, which is his position as the associate director of transfusion medicine and assistant professor, of pathology at Johns Hopkins in Baltimore, Maryland, a place, an area near and dear to my heart, Eric. I love it out there. I lived there for a while. I don't know if you knew that. I lived in that area for about 8 years.
Oh, that's interesting. I actually have no connection to Baltimore, so we should talk about that.
Off mic, maybe we'll do that. A little bit more about what you're doing. Eric has clinical and research interests focused in the area of safety and efficacy of blood transfusion and therapeutic apheresis. In particular, Eric is interested in developing algorithms to predict adverse events related to blood transfusion. And as a part of that, Eric is a co-investigator on one of the really big studies going on right now, supported by the National Heart, Lung, and Blood Institute. It's called the Recipient Epidemiology and Donor Evaluation Study, Part 3, and commonly known as REDS 3, and Eric is focusing on the impact of blood transfusion on recipient vital signs and pulmonary injury. He's doing some other work as well, including a post-marketing surveillance study looking at the relationship between platelet transfusion and pulmonary injury in hem-onc patients, and finally spends a lot of his time doing work in patient blood management, emphasizing, again, evidence-based guidelines for the initiation of blood component transfusion. I want everyone to know, Eric, this will probably embarrass you a little bit, but I heard you introduced at the 2016 AABB annual meeting as a rising star in our industry, and I actually have to agree with that. So congrats on rising star status, dude.
Thank you so much. I appreciate
it. And with that, I'm always interested in. We've just talked about your bio, obviously, but that's not necessarily your story. I love stories. I've said this before. I love hearing what it is that pulls people in the direction of transfusion medicine. So, what was it for you? What was it during your residency? What was it that made you think, "Wow, transfusion medicine, that's the ticket for me"?
Well, that's a really good question. When I was in medical school, when I first went to medical school, I thought I wanted to be a vascular surgeon. And after that, I thought that I wanted to do internal medicine, and I was really interested in patients who have liver disease. And at the end of medical school, I was really torn between going into internal medicine and probably looking towards hepatology versus going into pathology, because I'd also had experience working with the liver pathologists at Mount Sinai while they signed out liver biopsies. And in the end, for reasons that I'm still not entirely sure exactly why, but I decided to do pathology. And when I went to Vanderbilt, they have a very strong GI pathology program there, and that was a lot of what attracted me to it. But unexpectedly, I was actually assigned to a transfusion medicine rotation early in residency. And as soon as I had that experience of being able to see patients and make decisions, but still kind of have a laboratory medicine pathology, orientation towards the world, that's when I knew right away that I wanted to do transfusion medicine. And so right after that, that was really what I did, and I haven't looked back since then. So it took me a while to have the realization, but once I was exposed to it, I never looked back.
Ah, that's awesome. So a lot of times, Eric, I hear from people that have the kind of experience that you do that there were some particular mentors or some people that kind of, wow, they really showed you the way. Are there any mentors that you'd like to give a shout out to?
Oh, absolutely. At the very beginning of my residency, Dr. Pompey Young at Vanderbilt was actually the only blood banker at that institution. And she really took me under her wing and showed me basically everything that there is to know about transfusion medicine. As time went on, there were other people that really helped me a lot. And those people included Garrett Booth, who's also at Vanderbilt, Chris Tormey at Yale New Haven, Jeannie Hendrickson at Yale New Haven, Ed Snyder at Yale New Haven. And now I have the opportunity to be working with Aaron Tobin and Dr. Paul Ness here at Hopkins. So I could never have gotten to where I am without the help of a whole room full of people.
Yeah, well, that's some high quality mentors there, my friend. Nice job. That's awesome. That's it really makes such a huge difference, and I'm really interested in mentorship in recent years, and just hearing things like that, it just warms my heart. So that's fantastic. Well, so I wanted to take some time today, Eric, to talk about something that I know is important to you, and is really should be important to all of us in blood banking. And I want to be really clear on where we're going with this. Today we're talking about sickle cell disease, but specifically, I want to make sure that everyone listening to this understands that this is not a discussion today where we're really going to spend a ton of time going into, we'll hit it just a little bit, sickle cell pathophysiology, nor is it really a full breakdown on, the full indications for transfusion in sickle cell disease. Those details are important and huge, and you can find those in other areas. We're really kind of focusing today from the blood bank side on some of the things that can happen as a result of transfusion in sickle cell and some strategies that we can use with sickle cell. So with that intro, Eric, I just want to make sure people understand where we're going and what the expectations are. Let's just start from the beginning. This is the Blood Bank Guy Essentials podcast, so let's do the essentials. What is sickle cell disease, and what can happen to someone who has sickle cell disease?
Well, sickle cell disease is a huge medical issue all over the world. it is it is a hemoglobin disorder that primarily affects people who are descended from sub-Saharan Africa. But there are also a lot of people in Central and South America, in India, in the Caribbean, in the Middle East, who inherit sickle cell disease. And there's about 100,000 people in the United States who have sickle cell disease. I think that there's more than 10,000 people in the United Kingdom who have sickle cell disease. And with that being said, probably 2 out of every 3 patient with sickle cell disease are born in sub-Saharan Africa. So it is an inherited disease. It is a disease that affects people in virtually every country from a whole range of backgrounds, and it has a lot of implications on the health of the people who are affected.
So, Eric, let me just interject for just a second before we hit some of those implications. Can just thumbnail it for us? What's the problem? I know obviously it's a genetic hemoglobin disorder, but what's the specific issue that causes these problems in sickle cell?
Well, patients who have sickle cell disease have a condition where their red blood cells do not maintain the usual donut shape as they traverse through the circulatory system. They have a tendency to form a kind of a sickle-like shape, which is why it's called sickle cell disease, because on the peripheral blood smears of affected individuals, you can actually see the unusually formed red blood cells. And these red blood cells, when they take on the sickle form, they have a tendency to get caught in the vasculature of the person. And so as a result of that, they can have injuries to their lungs, they can have strokes, they can have injuries to their joints, and unfortunately, there's no definitive way to simply cure this issue.
That's rough. So one of the things that people struggle with sometimes, I think, is just in the terminology that gets thrown out, and people talk about things like sickle cell trait. People talk about sickle cell disease, sickle beta thal, all kinds of language. Let's be clear on what we're talking about today. Are we just talking about sickle cell disease, in other words, the homozygous genetic defect, or are we going into some of these others as well?
So we're talking today about sickle cell disease, which includes people who are homozygous for hemoglobin S, as well as people who have hemoglobin S paired with beta thalassemia, which is a sickle cell disease equivalent. But people who only have one gene of sickle cell, so they have one hemoglobin S gene and have sickle cell trait, this conversation does not affect them because fortunately those individuals do not have these complications generally.
Got it. Okay. All right. So you mentioned a little bit some of the things that can happen in terms of issues with vaso-occlusion and lung problems, et cetera. Can we talk specifically about some of the things that people worry about with sickle cell? What are those specific clinical complications that we're trying to ultimately prevent with what we're talking about today?
I think that the most important issue is stroke.
Okay.
It is probably the case that 10% of children with sickle cell disease will have an ischemic stroke. And the clearest indication for intervention in terms of transfusion is for the prevention of stroke. But there are other problems that are equally problematic for people who are affected, and those include things like acute chest syndrome, which is a combination of sickle cell disease with a new chest infiltrate on X-ray, with a fever and usually an elevation in white blood cell count, and that can be a very dangerous and even deadly complication of sickle cell disease that is also a very clear indication for transfusion therapy. And there are other implications as well for patients who have sickle cell disease. There's a tendency to have issues with eyesight, including retinopathy,
Mm-hmm.
with kidney function as well, and also other medical problems related to their major organs. And transfusion is used in order to treat and in some cases to prevent these complications, which generally leads to uh, an overstock of iron
Mm.
in the body of the patients with sickle cell disease. And unless that is addressed, the iron can build up. It can also deposit in the liver, in the bone marrow, in the organs, in the heart of people who have sickle cell disease.
Hmm.
And those complications of iron overload can also be life-threatening.
So that's an important point, I think. I mean, again, I think when you're starting out in transfusion medicine, it's kind of easy to think, well, okay, so these patients have. I mean, let's just be as simple as possible. These patients have bad hemoglobin. Let's just transfuse them and give them a bunch of good hemoglobin, and everybody will be happy. So why can't we just transfuse these patients every week and have everybody be happy? And you've kind of already addressed that a little bit, but maybe if you could discuss that a little bit further. When you talk about transfusion, are you just talking about throwing blood in at regular intervals? Are we talking about something more extensive or advanced, or what?
Great question. So, for a lot of people with sickle cell disease, being transfused on a regular basis is the care that they receive, and it is appropriate care.
Mm-hmm.
But and because patients with sickle cell disease or sickle cell anemia are anemic, there's not a problem generally with transfusing them. You have to be careful not to transfuse them to have hemoglobins and hematocrits that are too high, because that can also increase blood viscosity and add to the issue of these sickle cells getting caught in the peripheral circulation. But for a long period of time, many people are transfusion dependent for quite a while. But the problem is that over time, they can develop high levels of iron, and for about 30% of people with sickle cell disease, they develop antibodies to
Ah,
minor red blood cell antigens, and that is what we call alloimmunization, and that's really where the blood bank tends to get involved
yep.
because we, on the one hand, want to try to find ways to prevent patients with sickle cell disease from alloimmunizing. And on the other hand, if they do alloimmunize, we want to make sure that we take their antibodies into account in the crossmatch, and that we issue them a unit of blood that is unlikely to cause any immune hemolysis.
Got it. So, and that's where we're going to spend most of our time today, I think, Eric, is talking about alloimmunization, all the way from why it happens and to trying to keep it from happening. One quick thing before we get there, I'm wondering. You mentioned transfusion is a viable and reasonable option for these patients. What about are there other options? I mean, are there any medications out there that patients with sickle cell are given that people are studying to maybe see if it works just as well as transfusion?
This is an area that is of a lot of active study and development,
Mm-hmm.
and it really depends. For each patient, there's a different um, approach here. In terms
Mm-hmm.
of medication, hydroxyurea has been used for a long time because hydroxyurea increases the percentage of hemoglobin F and can help to reduce the amount of hemoglobin S in circulation.
Mm-hmm.
Unfortunately, it is probably not the case that a treatment with hydroxyurea is as effective as transfusion therapy in preventing strokes in patients who've already had stroke.
Mm-hmm.
And so that needs to be taken into account. And there's an emerging interest in performing stem cell transplant on patients with sickle cell disease. This is where the donor of the transplant would be somebody who does not have sickle cell disease,
Right.
and the transplant is to replace it. The idea of that is excellent because theoretically it would replace the recipient's bone marrow with a new bone marrow that wouldn't make sickle red blood cells.
Sure.
It would seem that these stem cell transplants are probably better tolerated by younger people, And so for people who are older and who already have sickle cell disease, it's not clear that all of them would be great candidates for a stem cell transplant. And not everybody has a donor
Mm-hmm.
who's available to them. Even if they are a great candidate, finding someone who is a good match and who doesn't have sickle cell disease can be difficult. At least it can be difficult in the United States. So unfortunately, there's no perfect solution. People are talking about gene therapy, but that's probably quite a ways away.
Yeah, I gotcha. Okay. Maybe I fibbed a little bit at the beginning. I said we weren't going to get too much into that. So let's come back to what you were talking about. And so you mentioned that one of the potential complications in patients with sickle cell who are chronically transfused is alloimmunization. So let's go into that a little bit more. What is alloimmunization, and why is that a big deal? Why is it a medical problem?
Well, alloimmunization is a medical problem, but it's a greater medical problem for some populations than it is for others. And patients with sickle cell disease are a population of people for whom alloimmunization is more of a medical problem than maybe the rest of the population taken as a whole. And the reason for that is that if you were to do an antibody screen on 100 people of all different ages, all different backgrounds, but none of them had sickle cell disease, in all likelihood, you would find that less than 5% of those people would have a positive antibody screen, even if they had been transfused in the past.
Okay.
But if you were to take a population of 100 people who had sickle cell disease, who had been transfused throughout their life, and did an antibody screen on them, you would probably find that 30%, or maybe even more than that, of people had a positive antibody screen or a history of an antibody in the past.
Mm-hmm.
And so, it's not exactly understood why that is. We can talk about why that might be.
Yeah.
I'm sure you'll ask me that question, but
You read my mind. Go for it.
But people with sickle cell disease are in a tough position because they need to keep having access to blood, but they're more likely to form antibodies in response to blood than people who don't have sickle cell disease. So, it's different. It's different to get into a car wreck once
Mm-hmm.
and to go into the hospital and have to take a few transfusions due to blood loss, but then recover and live the rest of your life and not need blood transfusions unless something else happens to you later on in your life.
Right.
It's another thing to have sickle cell disease, and even in the absence of any kind of event happening to you, even if you don't get in a car accident, you don't get diagnosed with cancer, or you don't, have a complication of pregnancy, even in the absence of all these usual indications for transfusion, you need to keep coming back to the hospital in many cases and get transfusions on a regular basis. And that is why this is such an important thing for us to be working on and for us to find ways to deal with it. When alloimmunization occurs in the sickle cell population, we think that it occurs for the same reason as it does in any other group, which is that we transfuse red blood cells. Of course, we match for ABO type,
Mm-hmm.
but there are other antigens like in the Rh family, Kel, Kid, Duffy, that are mismatched between the donor of those red blood cells and the recipient with sickle cell disease. And so when the immune system sees the donated red blood cells and says, hey, you have some antigens on your red blood cells, which we don't have on our native red blood cells, sometimes for reasons that are not fully understood, the immune system says, I am going to react to that antigen and I'm going to form an antibody to it. And if that happens, then in the future, future transfusions need to be negative for that antigen.
Mm-hmm.
Otherwise, the patient's immune system will destroy those donated cells, and that's what we call a hemolytic transfusion reaction.
So Eric, that's we say that, and you've what you're describing, I've heard that said for forever, that, obviously that patients with sickle cell have a much higher risk, and the implications. I'm sorry, the reason why it happens, generally speaking, you see an antigen that you don't have, and potentially you make an antibody. But quite frankly, why the heck is this such a bigger deal for patients with sickle cell than it is for other patients who get transfused? I mean, is it simply an issue of the quantity of the exposure? Is there any demographic issue that could contribute to this in terms of the racial background of the donors versus the recipients? Why is this so different for sickle cell patients?
Well, that is a great question, and I think that the best way to answer it is for me to say that we don't know exactly why. That there are a lot of factors which probably play a role, but the overall reason, we can't point to it and say, it's because of this one particular gene or because of this one particular transfusion strategy. So let me start by giving the caveats.
Okay.
The caveats are that many people with sickle cell disease will be transfused their entire life and never develop a single antibody. Okay. That's number one. Number two, some people will be transfused, develop one or maybe two antibodies that will not be terribly troublesome for the blood bank to match for. And that'll be it. And then some smaller group of people may develop large number of antibodies even after just a few transfusions. Or may develop an antibody which is extremely difficult for the blood bank to match for future transfusions. And what we would probably benefit from in the blood bank more than any other single intervention, and this is from a transfusion medicine perspective, not from an overall sickle cell hematology perspective, would be some kind of test that we could perform on patients with sickle cell disease that would allow us to know into which category any particular patient would fall.
Right.
Because if we know that somebody just isn't going to form an antibody, then there's no reason for us to scare them by warning them about all the antibodies they're going to form that they're never going to form. And on the other hand, if somebody is going to go through their entire life and be transfused with hundreds, if not thousands, of red blood cell units, and the max antibody that they're ever going to form is an anti-Kel. Again, it's important for people to know about that, especially if the patient is a female, because these antibodies can cause hemolytic disease in the fetus and newborn. It'd be really important to know that and to try to prevent that, but to also know that there was a limit to how complicated the situation was going to get. But what we really need to know is who are the patients who aren't going to tolerate this therapy very well at all, who are going to develop antibodies that's going to make it difficult for them to find blood. Because the problem is that once you develop these antibodies, it complicates other treatment options for you. If you have several antibodies, it's difficult to bring you through stem cell transplant compared to somebody who doesn't have any antibodies. Because if any of your B cells survive conditioning and your stem cell donor doesn't produce red blood cells that are matched for your antibodies, then you could at least theoretically have a chronic lifelong hemolytic anemia despite the fact that you went through stem cell transplant.
Yikes. Yeah.
So, and that's a rare thing, difficult to describe, but that is on the table. So there's a lot that we don't know.
Yeah.
But there are hypotheses out there that have tried to narrow down what some of these factors are that have been studied. Some people who are molecular biologists have looked to see whether there are differences in expression of chemokine receptors in patients who form antibodies as opposed to patients who don't form antibodies. Differences in the tendency of immune cells to migrate in response to chemokines in the population that alloimmunizes compared to the population that doesn't. People have also looked at HLA antigen expression as a possible cause of or protection against alloimmunization. meaning that certain HLA expression patterns could possibly increase your risk of developing an antibody as a result of transfusion, while other expression patterns may be protective. And there's also been a lot of work done recently looking at inflammation, which I guess that inflammation is really thought of as the degree or the amount of circulating inflammatory substances like chemokines and cytokines. And it may be that people whose baseline immune status is more inflamed, that those people might be at higher risk for alloimmunizing compared to patients that maybe have less inflammation, which is a difficult and tricky thing to measure, and also something that is difficult to intervene on or change or do anything about. And then there are other factors too. People have looked at the ages of people who alloimmunize. They've looked at the age of the first transfusion. They've looked at the total number of red blood cell transfusions. They've looked at whether transfusions that occur as just a simple, IV through the arm transfusion, does that make you higher risk for alloimmunization compared to a transfusion done using an exchange methodology? They've looked at the sex of the transfusion recipient. All of these things have been factored in, and despite a lot of partial explanations and really interesting science done by really smart people, there is no algorithm that can be put together that says, okay, if your T cells migrate this much in response to chemokine and your inflammation level is above this, and you're female and you were first, transfused at age 6, that this is your risk of alloimmunization.
Right.
That doesn't exist. We just don't know.
Gotcha. Okay. So, I mean, obviously, from everything you've said, it's a whole lot more complicated than just saying, oh well, they just do it. And further, it's a whole lot more complicated than perhaps we've thought in the past. I mean, I've heard. I've been around this game a lot longer than you have, Eric, but I've heard almost from the start of my career that, hey, well, the biggest issue is that most patients with sickle cell are of African origin at some point, and most donors in the United States are Caucasian. So obviously that's the problem. There's a lot of differences, and there are differences obviously in expression of antigens. But from what you've just described, it's a lot more complicated than just that.
Well, it is, but to your point, people are recognizing that the exposure is a lot more. The exposure to foreign antigen, so to speak, so-called foreign antigen, just meaning an antigen that the donor cells express that your cells don't. I think that our understanding of that issue is probably more nuanced now than it was, when you were training, because
in the dark ages, you mean the Stone Age,
in the dim times.
Oh, that's cold.
No, but I think that we are making some progress there. It's just that it's difficult to know what to do with the information. So, for example, for decades, there have been recommendations that what we ought to do is we ought to serologically phenotype patients with sickle cell disease who are going to need blood transfusions. We should know in advance what minor red cell antigens they express serologically. So we should get out the expensive antisera, and we should type these patients for at least, obviously D, and big C, little c, big E, little e, and Kel at the very least. Right. And some people would say, let's also look at KID antigens and Duffy antigens and MNS antigens. And then what people have recommended is, for decades, is after you know what the patient's phenotype is in terms of what antigens they express, that what we ought to do is we ought to do the same tests on donors. And then to the greatest degree possible, we should make sure that patients are serologically matched to their donors so that they would have less likelihood of forming antibodies as a result of transfusion. The problem with this is that although this approach makes a lot of sense, and there are certainly reports from all over the world that have demonstrated, at least in some settings, that these strategies can either prevent alloimmunization or prevent the progression of alloimmunization, meaning somebody who has one antibody, if they're put on one of these serologic matching protocols, maybe they won't form an additional antibody. The problem is that there are also reports out there of these antigen matching strategies that are serologically based, having very little impact on the overall alloimmunization rate of a sickle cell disease population under study. And the other problem with it is that these testing strategies are very expensive because of the economics of the way that blood is provided in this country. If you ask your blood supplier to provide you a unit that is negative for several antigens, a red cell unit, the blood centers generally will charge the hospital on a per antigen basis for each one of those negative antigens.
Mm-hmm.
So if you're matching for 5 antigens, that unit might cost $400 or $500 more than a unit which was just off the shelf and where the antigen status hasn't been tested and isn't known. And because we don't know which patients are going to alloimmunize, some people out there say that we absolutely should pay for those units and we should do everything we can to prevent alloimmunization. Other people look at that and say that might not be the best use of the limited medical dollar for patients with sickle cell disease, because maybe 70% of these people aren't going to alloimmunize ever, in their lifetime anyway. So
Right.
Providing these units spends a lot of money, but might not do a lot to prevent alloimmunization. And the other reason why it's controversial is that there are limits to the accuracy and informative level of serologic testing, because it turns out, and this has been shown now for several years, if you were to take a patient with sickle cell disease and you were to serologically type them for expression of the big E antigen, and they typed positive, so we know that serologically this patient with sickle cell disease has big E antigen expression on their red cells, you might think that you could take a donor who has expression of big E antigen of their red cells and transfuse it into this patient with sickle cell disease and not have to worry about alloimmunization. But it has been shown that that's not the case, because the serologic test doesn't take into account all of the different variations, many of which are genetic, that go into the expression pattern of these red blood cell antigens. So unfortunately, you can take somebody who is serologically big E positive, transfuse them with red cells from somebody who's serologically big E positive, and they can form an anti-big E antibody. And
that's I want to make the point that's such a huge important point that I have referenced this in show notes from a previous episode, but there was an article fairly recent, I'm sure you're familiar with it, that Stella Chow put out on that very topic, and I'll reference that in the show notes, everyone. So that's a really important article to understand exactly what Eric was just talking about, that you can match. And it can appear like everything's a great match, and you can still get antibodies because of those variants, especially in the Rh genes. So that's a really important point, Eric. I'm glad you brought that up.
Absolutely, and some people think that the solution to this is to genotype donors and recipients, and so that you could actually provide a genetically matched red cell unit that wouldn't just be, serologically they match, but that we know that the expression patterns genetically are the same, and therefore, if they're the same, then there's nothing for the immune system to recognize, and there's no, at least theoretically, no risk of alloimmunization. But while there's been a huge advance in that, and there are blood centers that have, started genotyping their donors, and a lot of people have done a lot of work on that issue, there has not yet been a clinical trial that has compared alloimmunization rates in patients who receive genotypically matched blood to patients who receive serologically matched blood or just off the shelf serologically, unknown blood. And so, in the absence of a demonstration that the genetic matching strategy is successful, it is unclear in the minds of some people how to best proceed on that issue. And I think that the thing to do is to do that clinical trial. And there's a lot of reasons why that clinical trial would be very difficult to do. But if we could either show that these genetically matched units really are what we think they are, which is a huge improvement over a serologic match, or if we could show that they aren't, either way, those results would be incredibly informative and could transform, either allow us to put a lot of resources into genotypic matching, or could allow us the opportunity to move on and try to find a better solution if this one doesn't work.
All right, Eric. So what you've said is really important, and we've talked about a little bit about some of the things that can happen with an alloimmunized patient. In particular, we've talked in the beginning about how it can be challenging, really challenging in some cases, to find blood for them. I wonder if you talk just a little bit more about some of the other potential complications. For example, you mentioned hemolytic transfusion reactions at the beginning. Is there anything with sickle cell patients in particular that they're at higher risk for in terms of hemolytic transfusion reactions, a particular kind?
Yes. We believe that patients with sickle cell disease are at a much higher risk for delayed hemolytic transfusion reactions compared to the general population. So these are transfusion reactions that might not be immediately noticeable, but are still potentially very clinically significant and incredibly problematic for people with sickle cell disease. And there's also a rare but very, very concerning phenomenon called hyperhemolysis, which seems to be a particular issue for the sickle cell disease population. And this is a poorly understood hemolytic reaction where sometimes after a transfusion, not only are the transfused cells cleared by the immune system as they are in a standard delayed hemolytic transfusion reaction, but for some reason the immune system can also lead to the destruction of the patient's own red blood cells. So, for example, let's say somebody had a hematocrit of 23% and then had a transfusion. We would expect their post-transfusion hematocrit to maybe be 26%. If they had a delayed hemolytic transfusion reaction, we would expect that 26% to go back down to 23% because the transfused cells would have been cleared by the immune system. But if they have hyperhemolysis, then their hematocrit might go down from 26% all the way down to 15% or 10%, into levels that are extremely dangerous and that carry a very substantial risk of severe complications or even death. And the mechanism of hyperhemolysis is not well understood. It may be that macrophages are somehow activated and just end up eating up all red blood cells that they can find. But this is a rare but extremely dangerous complication of transfusion that seems to be primarily found in the sickle cell disease population.
And so scary. I mean, I don't know how many cases you've seen. I've seen a few, and man, terrifying, really. One thing I do want to bring out about hyperhemolysis, though, and get your take on this, Eric. So you see someone who you've transfused, who starts to have hemolysis, and I think it's tempting for clinicians, at least initially, to go, "Oh wow, the hemoglobin is dropping. I better transfuse again." What are your thoughts on that in someone with hyperhemolysis?
That is an extremely good question. I think that if you transfuse in that situation, that it's possible that you can make it worse. But it's also the case that if somebody has, a hematocrit that is in and of itself incompatible with life, that it may not, it may be that you don't have a choice but to transfuse. And so in those situations, the thing to do is to talk with sickle cell experts to discuss the particulars of this particular patient's case and to make the best choice that you can make based on the patient's specific situation. I don't know what the right answer is, but I agree with you. I think that sometimes people don't realize that if you transfuse into that situation, that you may make things worse than they were even before. And so that needs to be taken into account. It certainly cannot be the case that everybody with hyperhemolysis should be transfused. I would say proceed with extreme caution.
Well, I know you're a big patient blood management guy. Realistically, it's kind of on steroids, no pun intended. It's kind of on steroids, the choice that really anyone should be making with transfusion. What are the risks of this transfusion? What are the benefits of this transfusion? It's just that we're talking higher stakes potentially with hyperhemolysis, but really we should be, and clinicians should be, making those choices and making those evaluations with every transfusion.
I agree with you completely. It's when benefit is low, then there should be no tolerance for risk.
Yep.
When benefit is high, then there's an argument to be made that risk is acceptable. But it's the toughest thing to see are the transfusion reactions that occur in response to that second unit of platelets,
right,
or that third unit of red blood cells.
Yes. Yep.
And that's when you really have to wonder whether risk benefit was fully understood by the ordering provider.
Yep. Understand. Okay. Well, that could be a podcast in and of itself, Eric. So we better move on a little bit. So we've talked about some of the implications in terms of what can happen and what can be challenges after alloimmunization, and we've talked about difficult with getting blood for a patient. We've talked about delayed hemolytic transfusion reactions and potentially nasty hyperhemolysis. Is there anything else? Is there any other group of patients with sickle cell disease for which alloimmunization could be a big problem?
Absolutely. We can never forget about pregnancy and the effect of alloimmunization on pregnancy. So, most antibodies that are produced by patients with sickle cell disease are capable of mediating clinically significant hemolytic disease of the fetus and newborn. This is a scenario where the fetal red blood cells express antigens that the mother has antibodies to. So if these antibodies are IgG class, they can cross the placenta, get into the fetal circulation, and mediate hemolysis. And that hemolysis can be life-threatening for the fetus. It can lead to fetal death and demise. It is a very problematic and difficult thing. And so, when you see a patient with antibodies, it's tempting just to think, oh man, transfusion's going to be difficult. But if that patient is female, of childbearing potential, then you have to think to yourself, my goodness, not only might we need to be finding compatible blood for this patient, but should this situation become clinically significant during pregnancy, we might be looking at preparing red blood cells for intrauterine transfusion as well.
You've spent a great amount of time with us, Eric, and I really, really appreciate this. I want to close with just kind of bringing it back around, and we've touched on this a little bit already, but I want to just kind of get your take on where things are here in 2017 with strategies to prevent alloimmunization. What kind of things should blood banks be thinking about? What kind of things should clinicians be thinking about in terms of doing all that we can to keep this from happening? And again, I know you've already talked a little bit about phenotyping, genotyping, et cetera, but if you could just kind of give us the state of the art right now, what are our thoughts on the kind of the either the most common or the best ways to go about this?
Well, for patients, if you're transfusing patients who have sickle cell disease, I think that, I would strongly recommend that you have a way in your blood bank record of noting that a particular patient has that diagnosis. I think that that's the most important first step. It shouldn't be the case that the blood bank is unaware that a patient has sickle cell disease. Once you have an awareness in the blood bank that somebody has sickle cell disease, then I think that the standard of care is to have some kind of approach or policy towards how you're going to handle that. A lot of places these days say we're going to match, serologically match antigens for all patients with sickle cell disease, and they pick usually big C, big E, and Kel are what they match for at the very least. Some places may match for more. Some places may match only for a subset of that. I don't think that that having an upfront matching program serologically for every patient is a requirement. But at the very least, if somebody has shown themselves to be a responder, meaning that they have at least one antibody historically, I think that at least at that point, that you should start looking at serologically matching other antigens as well. If somebody has been transfused at your facility many, many, many times and has never formed an antibody, I don't think that you should feel compelled to start matching depending on your outlook on that. But regardless of what you do with the serologic matching, it's clear that it probably will not prevent all instances of alloimmunization. And so looking towards the future, I think a more detailed evaluation of genotype matching is certainly something that hopefully if we have this conversation again in 5 years, Joe, hopefully we'll be able to say, either that large-scale work has shown that it's effective or only effective in certain situations. And hopefully in the future we'll have a way of doing some kind of a test on people so that we know who is at higher risk for alloimmunizing and who's not. Because right now the only test that we have to do to determine that is an empirical test where you simply transfuse them and wait to see if they form an antibody.
Right.
And we have to do better than that test. That is not that is not the ideal test. So
awesome. Completely agree with that. That's hopefully we will connect one day, Eric, when I'm a little older and grayer and well, I don't know where you'll be. You'll still be young.
Well, we'll see.
Yeah. All right. Well, I think this has been a really great overview, Eric. We've talked about a whole heck of a lot of things, and I think you've given us some good strategies and have really helped us kind of understand what the stakes are. And the stakes are big. This is not something to mess around with. I will tell you that there was a time in my past where I have felt like, well, what's the big deal? If they make an antibody, you just deal with it. But it is so much bigger than that. And blood bankers need to understand. In particular, I love the point that you just made about how blood bankers should always know when they're dealing with a sickle cell patient. I think that's a huge and very important tip, that if that's those of you that are out there on the trenches, if that's not something that you're doing now, I would really work to make that happen so that you can know what kind of a patient you're dealing with. If you're dealing with a patient with sickle cell, the stakes are really, really high and you can't mess with it. So, Eric, I can't thank you enough for spending time with us today and helping us to understand all this. Is there anything that you'd like to leave us with as we close our time together?
Well, one last small point is that right now each hospital has basically its own proprietary knowledge of of patients who have antibodies. And this isn't just for patients with sickle cell disease.
Mm-hmm.
This is for everywhere. If I go downstairs and have my blood drawn and I have an antibody identified, then the Johns Hopkins Blood Bank is going to know that I have an antibody.
Right.
But if I go across town to the University of Maryland after getting in a car accident, they're going to have no idea. And there's no way for them to know because that information is not easily shared.
Wow.
And I wonder whether, and I know that I'm not the only one who thinks this, there are people who've been thinking this for longer than I've even been a doctor, but there has to be a way for us to have there be an antibody registry that appropriately balances everyone's privacy and concerns about that, which are very important concerns, but that balances those concerns against the fact that these antibodies need to be known. Patients can't, all of the work can't just be put on the patient to remember all their antibodies and tell people what they are. That in this day of electronic medical records, of podcasts and
Yes.
all this great stuff, there's got to be a way for this information to be shared. And in the last 10 years, we've seen these huge registries be made for prescription drug substances because it's been recognized that there's a problem when providers don't know where their patients are getting medication besides themselves. And I think that the situation is directly analogous. I think that there is a potential harm to health if a provider doesn't know where else somebody is being transfused and what antibodies have been identified on that patient. And so I think that if we've gotten to the point that we can pull up a prescription drug history by logging in through a website, then there has to be a way of being able to pull up an antibody and transfusion history so that we can be a little bit more organized in our approach, not only to patients with sickle cell disease, but all patients who are alloimmunized.
Completely agree. That's a great point. Great point. Well, Eric, once again, thank you so very much for being with us on the Blood Bank Guy Essentials podcast. I really, really appreciate your time. Thank you, sir.
It's an honor. Thanks for having me.
As we close this discussion, I really feel like there's still a lot more to be said about sickle cell disease. I think that Eric did a great job talking us through alloimmunization, and yet I feel like we still need to do some future episodes outlining more information on things like exchange transfusion, studies comparing the use of hydroxyurea with simple transfusion, and things like that. So really stay tuned. I think we will do that some more in future episodes. So my thanks to Dr. Eric Gehrie for appearing on the podcast today. Thanks, as always, to each and every one of you for allowing me to play a part in your journey toward mastery of blood banking. Please head on over to bbguy.org/subscribe when you have a chance. Get on my email list so that you won't miss any of the cool stuff that's coming. And also, next time you're on a computer, if you could do me a favor, just head on over to iTunes and give this podcast a rating and a review. It really helps others to see it and hopefully learn from it as well. So that is it for today. Thank you all again. And as we close, my regular reminder, I hope that as you go through your day, that you'll smile and have fun. And above all, never, ever stop learning. Thanks a lot. We'll catch you next time on the podcast.